Welcome to State of Reform's virtual leadership series with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
I don't think Jamie needs much in the way of introduction. You know, she and Access are really one of the nation's most prominent leaders in terms of state innovation and state reform. And she has been with us at the table in hosting state reform and driving this conversation really since day one. So we are tremendously indebted to you, Jamie. And without further ado, let me turn over the keys to the car and let you take her away.
Great, DJ. Thanks so much for inviting me to be a part of this year's conference and really to host a discussion about some of the challenges that Medicaid programs across the country are facing, including Access here in Arizona, and then to talk a little bit more about what we're doing in the midst of those uncertainties to stabilize the program. So I'm going to start with our standard level setting slide. I'm sure most of you who are tuning in are familiar with this slide. But just to level set a bit, the Arizona Medicaid program covers over 2.1 million lives, 29% of the state's population. We're a jointly funded program, federal, state, and county funding. We also cover over more than 50% of the state's births and 2/3 of the state's nursing facility days. We have over 98,000 registered providers now enrolled with Access. And we have, since the implementation of the program in the early 80s, operated under a mandatory managed care model where we contract with 15 health plans to administer the benefit on our behalf. And we do maintain a small fee-for-service program, which primarily works to serve our American Indian population under the American Indian Health Program. Just a quick note about what we've seen at Access over the course of the last 10 months in particular in terms of enrollment. We've seen a dramatic increase in enrollment since March of this year, corresponding with enhanced federal matching dollars, which had a corresponding requirement that prohibits us from disenrolling anyone over the course of the pandemic period. So we've seen our enrollment grow to the tune of 246,000 enrollees, a 13% growth in our enrollment over the course of the last 10 months. And I'm going to talk a little bit more about what that means for the program in a moment. So what we know is that we're currently living in an environment which presents unparalleled uncertainty for Medicaid programs across the country and certainly here in Arizona. And there are a few factors that are really driving that uncertainty. One, the trajectory of the pandemic. At the National Association of Medicaid Directors conference last month, Scott Gottlieb spoke, and he said that we were really headed into the worst phase of the pandemic. And we're clearly seeing that play out with almost 3,000 deaths in the United States yesterday alone. And that has real consequences for Medicaid programs. So while in Arizona, we're very fortunate currently that our economic forecast, according to the Joint Legislative Budget Committee, looks very favorable. That could change if the pandemic continues to play out in a way that we're not able to really control it. We have a lot of optimism, of course, with the vaccines, but certainly there's no a definitive certainty around how things are going to play out in terms of the trajectory of the pandemic. In addition, the public health emergency that was federally declared by the administration on March 13th must be extended every 90 days. And there are two items that really are important when we talk about that in terms of Medicaid programs. One has to do with the enhanced federal match that Medicaid programs received with the passage of the Families First Coronavirus Act early on in the pandemic. Every Medicaid program received an additional 6.2 percentage points in federal matching dollars. But with the receipt of those additional federal matching dollars, again, we're prohibited from disenrolling anyone who is enrolled in the program at the onset of the pandemic. So really causing those dramatic increases in enrollment in every Medicaid program across the country. That particular measure, the enhanced federal match and the maintenance of effort requirement, are tied to the PHE. meaning when the public health emergency is terminated, the enhanced federal match will be terminated as well at the end of the quarter in which the PHE ends. The maintenance of effort requirement will term as well at the end of the month in which the PHE ends. So tying the enhanced federal match and corresponding maintenance of effort requirement to the public health emergency creates a tremendous amount of uncertainty for Medicaid programs across the country from a budgetary perspective and from a planning perspective. And the example that I'll give you, when we submitted our initial budget request for FY22 to the governor's budget office in September, we projected an enrollment increase from 20 to 21 of 6.2%. And that was assuming that the public health emergency would term in October. And that's what we knew at that point. With our budget revision submitted just a week and a half ago, the PHE had been extended to the middle of January, and that's where it sits right now. It's due to term in the middle of January, if not extended further. So with our budget revision, our projection changed, and we're now projecting a 7.2% increase in enrollment from FY20 to FY21. And that will continue to change as we see how things play out with the federally declared public health emergency and whether the current administration or the new administration decides to extend it beyond that January, mid-January term date. The other piece of the equation with the public health emergency for Medicaid programs has to do with the flexibilities that we've implemented. We've implemented a whole host of flexibilities over the course of the last 10 months to ensure member access to care and to ensure the ongoing viability of our provider network over the course of the pandemic. Many of those flexibilities, like an abbreviated provider enrollment process, allowing parents of children in our All-Tex program to be paid for services that are offered to their children in their own home, telehealth benefits. Many of those flexibilities are tied to the public health emergency and will term once the PHE terms. So again, a level of uncertainty in terms of how things will play out, given that the PHE must be extended every 90 days. And the future of the Affordable Care Act. We all know that the Supreme Court heard arguments on the ACA shortly after the election. We have some level of optimism. As you may remember, Justice Roberts and Kavanaugh indicated that they really questioned the plaintiff's argument that the assertion that the ACA must be invalidated if the individual mandate is eliminated. So that gave us some level of promise, but we clearly won't know how things play out with that case until spring or summer of 2021. And then the Biden administration priorities. It's a new world, right, for us, and it remains to be seen what the administration will do early on in their tenure. There's a lot of speculation in terms of their interest in rolling back some of the changes that the Trump administration made, particularly around the marketplace, perhaps sponsoring a special enrollment period. And then there's also a lot of discussion around the public option and what the public option means for expansion states versus non-expansion states. So more to be seen on that front, but something that we're watching very, very closely. So the question becomes, what are we doing as Medicaid programs, both at the national level and in our own states, to create some level of stability in the midst of all of this uncertainty? First of all, we're really taking advantage of the resources that the National Association of Medicaid Directors brings to bear around the federal level policy discussion. We have urged the administration to establish metrics to evaluate future extensions of the PHE. So for instance, establishing a metric such as a nationwide positivity rate. If that positivity rate would drop below 5%, then perhaps we could term the PHE and states could continue on without that additional federal assistance or the flexibilities that we've offered. But establishing metrics would create a level of certainty in terms of when that PHE would end and would help state Medicaid programs to plan more confidently going forward. Also, we have asked that our congressional delegation and congressional representatives at the federal level consider an enhanced federal match beyond the one that they're currently offer, which is 6.2 percentage points. We have requested that they increase that match further to 12 percentage points. And probably more importantly, we've asked that they sever the link between the public health emergency and the enhanced federal match, allowing, again, a level of certainty for states as they try to plan and work with policymakers in the state around the state budget. We've also asked our federal partners to take the Medicaid fiscal accountability rule off the table, otherwise known as MFAR. Many of you on the line may be familiar with MFAR. It's a regulation that really attempts to draw some parameters around supplemental payment programs in states. And while we agree as an association and as a program here in Arizona that transparency and reporting are absolutely critical when it comes to those supplemental payment arrangements, there are other components of MFAR that would be really problematic for Arizona because, as you know, we have a couple of assessments and corresponding supplemental payment programs that are really important to our maintaining our expansion program and maintaining the viability of providers in our network. We also have asked our federal partners to really think about providing an upfront investment to states who are interested in pursuing innovations, in particular innovations around social determinants of health. As we all know, social determinants can play an incredible role in individuals' health outcomes. And so as we have indicated in the past and continue to explore in Arizona, that the real merit of extending our notion of integrated care to include social determinants and think about the role that things like housing, employment, social isolation, and food insecurity can play in terms of individual health outcomes, and asking our federal partners to dedicate resources in that regard as well. So what are we doing at the state level in terms of stabilizing our program in the midst of all of this uncertainty? Well, clearly over the course of the last 10 months, we've been engaged in a very robust and thoughtful effort to, again, ensure member access to care and continue to maintain member access to care over the course of the pandemic, and maintain the viability of our provider network. And that has really involved a series of response efforts over the course of the pandemic. Provider relief. We've provided a tremendous amount of provider financial relief over the course of the last 10 months, including $60 million in additional funding to providers like nursing facilities, assisted living facilities, critical access hospitals, and we've advanced or accelerated $90 million in funding to various providers, including providers that are engaged in our targeted investments program, which is a program that where providers demonstrate their commitment to integrating care at the point of service, as well as hospitals that participate in our GME program. And that's allowed those providers to maintain a level of stability over the course of the last 10 months. Very important effort on the part of the Medicaid program. We've also further expanded our telehealth benefit. So for those providers that were seeing a dip in utilization at the beginning of the pandemic, the expansion of that telehealth benefit allowed them to continue to provide services and allowed members to access services when they were hesitant about obtaining services face-to-face at their local clinic. Vaccine strategies. We've implemented a strategy already around the flu shot, offering a 10% increase on a variety of codes for the vaccine and the administration of the vaccine, offering a $10 gift card to members when they obtain the flu shot, and also allowing pharmacists to administer the flu shot to children ages 3 through 18. We are currently finalizing our strategy around the COVID-19 vaccine. I'm happy to report that we will be able to reimburse for the administration of the vaccine at Medicare rates, which are above and beyond our access fee-for-service rates. We expedited provider enrollment early on in the pandemic to allow providers to come into the state from out of the state and enroll through an abbreviated enrollment form without a fee and without a site visit. So really important as we struggle and continue to struggle really around ensuring that we have a sufficient provider capacity within the state to serve individuals who are COVID positive. We are waiving premiums for individuals in our kids care program and have done so since almost the onset of the pandemic. That's been really important in ensuring that members in the kids care program and families are able to access care. And again, we've offered payment to the parents of minor children who are receiving services in their own home and are clearly hesitant to bring other members or other individuals into their own home. Those parents are able to be paid for those services. Another effort that we're engaged in that I think is really important from a stability standpoint is simply the renewal of our 1115 demonstration waiver. The application is due at the end of the month, and we have a number of efforts that we're proposing in conjunction with the renewal. One of which is very important, and that's the extension of our targeted investments program. Again, the targeted investments program is a program that offers incentive funding to providers who have partnered with us in integrating care at the point of service. It's been a tremendously successful program over the current waiver period, and we're seeking to extend it in the new waiver period to providers that haven't participated to date, and also to expand the expectation for providers that are currently participating. Again, looking at integration at another level and bringing in the non-clinical component of integrated care, extending that notion to connecting members to critical social services. Also, under the 1115 waiver renewal, we're really happy to report that one of our proposals has to do with the ability to reimburse for traditional healing services. This is a proposal that we've been working on for many years with the American Indian community in Arizona, and it's something that we felt was really important to offer in conjunction with our waiver renewal proposal, again, to address some of the disparities that exist within our program and within programs across the country. In addition to the 1115 waiver renewal, we're really starting to delve into the examination of health disparities that exist within the Medicaid program in Arizona. We've established a health equity committee, and their specific charge is really to look at the data that we have in our system, identify any disparities that may exist, and start to develop meaningful interventions to address those disparities. This is an effort that is really prominent across the country within Medicaid programs. And so we are looking to some of our other state partners to help guide our efforts in this regard as well. But again, an important part of stabilizing the program going forward and ensuring that we are committing to equal access to care for all populations. Our Whole Person Care Initiative, an initiative we launched last year, again, really focused on expanding our notion of integrated care to include social determinants of health, because we know that 80% of an individual's health outcomes can be tied to something other than their clinic visit. This is an incredible initiative, an initiative we remain committed to. And with our 1115 waiver renewal, really looking at some of those opportunities, perhaps in the area of housing, where we could really maximize the state dollars that we have for housing currently, and perhaps draw down federal funding to match those state dollars so we can extend our efforts in terms of providing housing and housing supports and services to the 2.1 million members served by the program. And then workforce redesign. I know all of you that are tuning in today are probably facing a lot of questions around what your workforce is going to look like going forward. This is really a silver lining for access and an opportunity for us to generate some savings for the state. We've determined over the course of the last 10 months that 66% of our staff are able to work from home long-term. So we have carefully monitored productivity levels during the last 10 months and looked at the benefits that that virtual office environment brings to our workforce. And what they've told us is it generates savings for them, it creates more work-life balance, and that oftentimes they find that they can be more productive in a remote work environment. And our productivity levels haven't suffered. And I will tell you, we were very lucky to have the Arizona management system, which is a system, a lean management system that was advanced by the governor early on in his tenure, to really guide us in terms of measuring productivity. And we haven't seen a decline in productivity as a result of this shift. And we actually have 85% of our staff working at home right now, and they'll remain in that environment through the spring, we believe, when the vaccine is widely available. But long-term, 66% will remain at home. We're very excited about this change and excited to report that we know that it will generate at least $1.2 million in savings annually for the state. And so that's another effort that we're undertaking to stabilize the program and to also contribute to efforts in order to stabilize the state's budget as well. So at the end of the day, for us at Access, it all comes down to those that we serve. So I wanted to include this slide. This is a story about one woman. She's a single mom raising 3 boys with significant developmental and behavioral health issues. She lives in a rural area of the state and lives with her extended family, which can sometimes be challenging. She reports that her family has consistent challenges with transportation. And as I mentioned, at the onset of the pandemic, we extended our telehealth benefit pretty dramatically, including the provision of telephonic services. And what we know is that's made a difference in the lives of those that we serve. And that's what you hear from Julie today. Access allowed us to continue accessing services during the pandemic in our own home, on our own schedule. And that's what, at the end of the day, is the defining factor for us. At various points during the pandemic, we faced really difficult decisions. And there were times when we didn't know which direction to go, but we'd always come back to, what do we need to do in order to provide the best service possible to those that we serve? And when we put the member at the center of that decision-making process, we made the best decision that we could for the program and for the state. So with that, DJ, I'll turn it over for any questions. And
I gotta take my microphone off mute. Good Lord, you'd think after 9 months of doing this, we'd all know how to do that, but apparently I didn't. Thank you, Jamie. I want to reorient us all here real briefly to process for now, and of course throughout the day, which is to say, on the right of your screen, obviously you see a chat box and a Q&A section. You can of course post your questions there, upvote them throughout the day. I'd really encourage you to do that. I know that we see in our analytics about half of our attendees have, they're multitasking, and that people have this playing in the background. But I'd really encourage you to come in, particularly now during our keynote and throughout the day, to engage with folks and post a comment or two to make sure that your voice is part of this discussion. So a couple of questions here early. Jamie, Len Kirshner asked about the 1115 waiver, and you spoke to most of that, but he asked about a clarifying question about when the current waiver will expire. I know you said that you're going to submit your application here this month, I believe, or before the end of the month. Yeah. Sometimes Biden or a new administration can take time to get up and running. Give us some detail about expiration and what would happen if the Biden administration takes too long to fully review the application.
Certainly, great question. So our application is due by the end of the year, exactly as you stated, DJ. The actual waiver is due to expire on September 30th of 2021. So essentially, when we submit that application, that kicks off a 9-month negotiation period. And we have a level of confidence, having interfaced with CMS pretty closely, as you can imagine, over the course of the last 10 months in relation to the waiver and a number of other issues. We have a level of confidence that over that 9-month period, we'll be able to successfully negotiate the various elements of the waiver. And we actually do anticipate at this point that we'll have a couple of amendments following the submission of that application, one of which we hope will speak to our interest in, again, federalizing some of those state level housing dollars.
Yeah, good. Michael Goldberg asks, said that the Whole Person Care Initiative had been, well, he says, this fall Access announced that it will refrain at this time from the pursuit of a broader whole person care initiative in conjunction with its 1115 waiver. Can you talk more about the smaller scale, cost-effective initiatives within the parameters of the existing Medicaid program that Access says it will pursue instead? I think you spoke to this a little bit, but can you speak directly to the kind of replacement strategies for the whole person care initiative?
Sure. And really our decision around kind of pulling back on the whole person care initiative was really around the uncertainty that we're facing related to the economy. Again, things are more favorable now than they were even 5 months ago. So we may shift again in that regard as we negotiate through the waiver. But some of the things that we're pursuing in the meantime, we're looking at items around housing, transportation, and social isolation. For instance, with our transportation program, looking at the more extensive or expansive use of bus passes. So that's available already in our program, but we haven't heavily promoted the availability of bus passes. And when you offer someone a bus pass, clearly they can use that bus pass to go see their doctor or to go to the grocery store or to go to a job interview. So that's one effort we're undertaking. In regard to housing, you may know that we are centralizing the administration of our housing program. We feel like that's going to be really beneficial in ensuring that individuals in our program have equal access to rental subsidies and housing supports and services. So the RFP was released earlier this year, and we're actually currently evaluating proposals. And we think that again, in terms of one of the social determinants that we focus a lot of energy on, which is housing, will be beneficial to our membership. And in terms of social isolation, really looking at opportunities to better connect, in particular, young adults in our long-term care program with peer supports. And so extending our notion of peer support services and allowing them to better connect with their community by connecting with individuals that are their peers within the program.
I know you've been talking about this, but I want to give you an opportunity to keep talking a little bit about it. Erica Crouch asks a question, or first she says, thank you for these updates. Exciting news about the expansion of the Targeted Investments Program. Can you share a little bit more about your vision for integrating social determinants of health into this program? Again, you've been talking about that. I just want to give you an opportunity to kind of expand on your thinking about this integration.
Absolutely. It's one of the things I'm most excited about, actually. So we've been engaged in this integration journey for a decade plus, but it's really been focused around the integration of physical and behavioral health services. And then with our justice clinic sites, there's 13 of them around the state. We have individual locations where members that are transitioning from a correctional setting back out into the community can obtain parole services, behavioral health services, and physical health services in one setting. With this expansion of the Targeted Investments Program for those providers that have been involved, we expect to establish milestones that really push the envelope in terms of expectations around connecting individuals with community supports when we identify a social service need. So taking us really to the next level in terms of our integration journey. I'm really excited about it. I'm excited about the thought that an individual leaving a correctional setting could walk into one clinic space and find that their physical health needs, their behavioral health needs, their parole officer, and their social service needs can be met in that one location. And part of that process is establishing what we call a closed loop referral system, which will allow clinicians through an automated process to more easily refer people to social services out in the community. A lot of providers have been doing this important work for many, many years. This is simply a way for us to reward them for that important work.
Jim Hammond from the Hertel Report says that Vitalis estimates that there are a number of low-income and unemployed folks that are currently eligible but not applying for Medicaid benefits. So, particularly as we see the economy in Arizona turn around, his question is, how is Access trying to engage these folks that are eligible but not enrolling for Medicaid? And I wonder if it actually gets maybe more important and harder to do that as top line numbers look like they're going in the right direction, but at the lower ends of the income spread, it looks like folks are going to continue to struggle even more acutely. What are your thoughts?
Yeah, and really since the onset of the pandemic, and when we started to see those unemployment rates skyrocket in the state, we started to reach out to community partners that we know have been active in the space of engaging those individuals that might not be enrolled, to help them enroll with the system. And so it includes community partners like Vitalis, like the Family Involvement Center, who've done this work for many, many years. But we really rely on that network of community partners. And I spoke on a panel yesterday, and I think, an instance like this with the pandemic is really an opportunity to create unity. And I think in Arizona, you've seen that occur at a level that perhaps you haven't seen in other states. And it's something I'm really proud of, in our state, in that all of the resources that we needed to bring to bear have come together to ensure that we were able to serve our membership. We were able to enroll those individuals that needed to be enrolled in the program so that they could access care, whether it's the Council of Human Service Providers, or it's another state agency, DCS, ADOA, or it's an organization like Vitalist, or our health plans. Our health plans have been really instrumental, but we've really taken advantage of what is a really challenging situation to come together and to problem solve as a community.
Let me ask you about telehealth. You mentioned it. There is an active conversation that takes shape in different ways in different states and different parts of the community in Arizona. But some folks say, hey, it costs a lot less to deliver care via telehealth, and therefore reimbursement should come back down. Others say we've finally catalyzed expansion of this tool by reimbursing at a comparable level to in-person settings. All of this is really driven by state and federal regulation, particularly federal. But what are your thoughts as a payer, as a policymaker, about telehealth in general? Is it appropriate to be? Is the level of compensation appropriate to be at an in-person setting in the post-COVID space? Should that revert back to a lower reimbursement because of the cost differential? What do you think?
That's a great question, and it's something we're currently evaluating. DJ, at the onset of the pandemic, we mandated that telehealth services be reimbursed at the same rate as in-person services over the course of the public health emergency. But we have a work group established now, not only to look at whether we need to maintain that mandate in terms of reimbursement, but also to look at what the benefit needs to look like long-term, meaning, are there clinical guardrails that we need to put into place in order to ensure that we're delivering care in a manner that's consistent with basic clinical practice? And so that work group will really inform what the benefit looks like going forward, including telehealth services as well as telephonic services, which have been, frankly, really important over the course of the last 10 months because we realized really quickly that there were providers, and most notably members, that didn't have access to audio video equipment.
Yeah. Let me ask this sort of last question as we start to wrap up here. And this is just about your own experience as a leader at Access, both with external responsibilities, meaning the beneficiaries in the state of Arizona who rely on Medicaid services and the purchasing power of Access, but also as a leader of your employees at the agency. What has been the most challenging part of leading through COVID, and what from this time has given you the most hope about the future?
Sure, great question. I think the most challenging part of the last 10 months has been that we had to make decisions very, very quickly in many instances, particularly early on. And as you know, DJ, and as those watching know, we are a very rule-oriented, data-driven organization. And what that meant is that there were times when we had to make decisions without all of the data available. And what that meant is we often had to rely on other resources, such as community partners that could help us gauge the degree of the problem or the direction that we needed to head. And again, I think their input was critical, but that was really challenging for us as an organization because we do rely on data to make decisions generally. But it was a great learning experience for us as well. And I think it helped us to really make some connections with community partners that we wouldn't have otherwise. And I think those connections and partnerships will remain well past the pandemic. And I'm sorry, the second part of your question.
Yeah,
BJ?
what gives you hope about the future given what you've seen during this time of COVID?
Yeah, and I'll go back to what I said just a few moments ago. I think situations like this create an opportunity for the community to come together. And in Arizona, we've taken advantage of that opportunity. And I believe the partnerships and the strength in those partnerships that we built over the course of the last 10 months will remain well beyond the pandemic.
Jamie Snyder, the director of the Arizona Healthcare Cost Containment System. Thank you, Jamie, for making time to be with us. I appreciate it.
Great to be with you.